Good afternoon. I'm Al McFarlane. Welcome to The Conversation with Al McFarlane. I'm glad to be here and glad to have you along as well. Got a great program for you as always. Our focus today is going to be on health, particularly maternal health and other topics beyond that, Medicare, Medicaid, what services, what information you need to navigate. But our theme is going to be maternal health, and we're pleased to have experts in that area to be on the program today. My guests today are going to include Dr. Diane Banigo, who's a social architect and nurse-midwife health consultant. Also pleased to have the commissioner of Minnesota Department of Human Services, Jodi Harpstead, and Dr. Nathan Chomilo, Medicaid medical director at the Minnesota Department of Human Services. So great people, a great program. You're going to enjoy it. What we promise always is robust conversations. So buckle in. We'll have a great one today. So, I want to begin, though, by, as I always do, inviting you, the viewers and listeners, thanking you for tuning in to the program, first of all, letting you know that we are streaming this program live every day across 5 different platforms. We're on the YouTube channel for the Black Press of America. Black Press of America is like the National Newspaper Publishers Association, an organization of over 200 Black newspapers. And the organization reaches millions of Black people. We're also streaming on the YouTube channel for Insight News here in Minnesota. Besides that, we're on Facebook for the Black Press USA, Facebook for Insight News. We're on LinkedIn and Twitter. I want to invite you, if you're on any of those platforms, to go over to the Insight YouTube channel, and become a subscriber. And our goal is to document the engagements we're creating, and we're growing. We've got around 300 subscribers now, but we want to move that to 1,000. We do have 30,000 views of our program so far, and that's great. We want to move that into the stratosphere. It takes time. It takes your help. Do what you can. What you can do is go to Insight YouTube, look for this program, and subscribe. And we thank you in advance. Well, let me begin, as we often do, with we call it a hot topic. And today, everything, in my view, is about what's happening over at the state legislature. And on yesterday's front page, I think, of our Insight News, an article entitled "Minnesota House Approves $1.9 Billion Public Works Package." It's an article by Steve Karnowski from Associated Press. And it's important. The picture with it is really cool because it has 2 North Side legislators delivering this information. One is Fu Lee, who represents the North Minneapolis Camden neighborhood, and also Melissa Hortman, who is of Brooklyn Park, and she is the leader, House Speaker. So they are at the Capitol sort of presenting the House's approval of the $1.9 billion public infrastructure package. And they note that it presented with bipartisan support. This happened Monday. And this package proposes to fix up bridges, water systems, college facilities, and parks and trails across the state. And when they're done, what they've done now, it's going to be going over to the Senate. It's going to have some challenges in the Senate. Most of the individual projects in this package were ordinary, unglamorous, non-controversial. They focused on maintaining or replacing existing but aging assets in the legislative districts statewide. But the conflict for the Senate is how these improvements will be paid for. And on the one hand, the legislature is calling for $1.5 billion in borrowing. It's called a bonding bill. But there's another strategy that calls for about $400 million in cash. And watch the news. Pay attention. Here's a place where I think the Republicans want to just give money back and not address the infrastructure, or to address it differently. And the Democrats are saying, let's be mindful, great stewards. Let's fix these things need to be fixed. But you check it out. It's important. And weigh in. Let your voice and your interests be known and be clear. Well, today our topic is going to be health and maternal health, and I'm pleased to have these great guests. I want to start, however, with talking to the commissioner. I'm so glad to see you again, Commissioner Jodi Harpstead. And Jodi, I want you to talk about how the state is supporting community-led initiatives to support healthy pregnancies and improve birth outcomes in Black and American Indian communities. But beyond that, other priorities that you've undertaken as the commissioner, the leader. Let me tell people that the governor named you commissioner, Governor Walz named you commissioner in August of 2019. And prior to that, you were the president of Lutheran Social Services in Minneapolis. There, at least I think about 10 years or so. You've also been executive vice president and chief operating officer for Lutheran Social Services. And you also spent a number of years at Medtronic Incorporated. So you've got a lot of civic engagement activity in places like Augsburg University and beyond. Your background includes a master's in business administration and finance and bachelor's degree in business administration from Michigan State University. Commissioner Jodi, welcome to the conversation. So good to see you again.
Thank you, Al. It's good to see you too.
Well, so, the topic is how do we serve women and how do we help them in pregnancy and make sure that they are successful and that their families, I want to use that simply as a point of departure. So address that as your department's role, but take that to go into the overall health and well-being of the residents, the citizens of Minnesota.
Yes, thank you. So I have to say, Al, before I took this position, I had no idea there was such a difference in birth outcomes for Black and Indigenous birthing people versus white people. And I just didn't know about that. And I know about it now because 8 in 10 of Minnesota's African-American births are insured by medical assistance, which most people call Medicaid. Here in Minnesota, and the Department of Human Services manages the Medicaid program. So you can't avoid these data now where I'm working. And I have to give great kudos to our second guest here, Dr. Nate Chomilo, who's our medical director, who's particularly elevated these issues for us and taught us all so much about them. We've done a lot of conversation, a lot of listening with community over the last few years, and really learned about the disparities in Minnesota. These issues of pregnancy and birth disparities are true across the nation, but unfortunately, we've had to say so many times in recent years that Minnesota has some of the worst disparities for birth outcomes. Native American and Black birthing persons have higher rates of giving premature birth, and Native American and Black birthing persons in Minnesota have higher rates of low birth weight. And so we've, again, learned a lot about these things. We've had wonderful community partners who are engaged in this work with us, who've taught us what their communities know about what works for the birthing persons in their communities and their basic backgrounds and traditions. And so we've learned so much in recent years, and we just have to give credit to the community who came forward to talk with us about these issues, to bring their solutions and tell us what they needed. And then our work, of course, always at the department is to turn everyone's hopes and dreams in the community into proposals for the legislature, funding, and regulation. And we've been able to do quite a bit of that work in recent years.
You've got a big organization. Give people an idea of the scope of your portfolio at your department.
Yeah, so the Department of Human Services, as I mentioned, runs the Medicaid program, which is the largest part of our $23 billion budget. It's about $18 billion of that. We also have people who develop policy and help to write proposals for the legislature from birth to seniors, people with disabilities, and everyone in between. And then DHS also runs a hospital system for people with behavioral health. We call it our direct care and treatment facilities all across the state of Minnesota. So a very large behavioral health system. You can think of it as about the same size as the Centracare system in central Minnesota. So 7,500 people, billions of dollars. There's a lot going on. And so I have to say it took something for Dr. Chomilo to reach in and look for this data that we have on Black and Indigenous birthing people and their birth outcomes and their pregnancy outcomes and pull it to the top and really show us the work that needed to be done. As we came out of the pandemic here over the last couple of years, or at least out of it so far, we were able to go back and renew our Medicaid contracts with managed care organizations across the state. So we have brand new contracts with our Medicaid managed care partners. And as part of that process, we talked with those folks about creating those contracts. We asked them for whatever data they had on equity of the work that they do. And they had to have good scores in equity to get those contracts. And then after we did that, we asked them to commit to certain quality performance improvement projects together over the next several years. And they chose to work on maternal and infant health disparities and outcomes, partly because they're well aware of them themselves and partly because Dr. Chomilo and others made them well aware of these issues and they decided to take them on. So we have an opportunity every year when we true up the financing of those managed care contracts to withhold dollars from those organizations if they have not made the progress they said they would on reducing these disparities. So it's a large tool that we have in the Department of Human Services to work on particular issues in healthcare and especially health equity.
How are you reporting out your finding or your progress to the public? Are you discovering that capacity you have to either incentivize or punish people that produce or don't produce in the arena of equity? Is it producing results so far? If it is, how do you categorize or capture those results and report them out?
That would be a better question for Dr. Chomilo, who would be the one doing that work.
Okay, well, I'll ask him that question. Before I switch to him, let me ask you, Black Maternal Health Week is coming up in April. And what are some of the discussions that should be at the forefront of people's minds, not only that week, but year long, when it comes to the question of Black maternal health?
Well, certainly that would be a golden opportunity for us to share whatever data we have from the work that we've done so far. I was at a roundtable last year on this issue and was a rich discussion deep into various neighborhood organizations, understanding what they're doing them up for the really proud work they've done to make a difference in this space. And so I should mention that back in 2015, we launched some grants called the Integrated Care for High-Risk Pregnancy Grants, or ICHIRP. And several coalitions of organizations came around to apply for those and get those grants. And the last time we met with them out in the neighborhoods, they really just got together to celebrate all the really great work they had done and the improvements they've already made in their neighborhoods with these grants. So we know that great improvement can happen if we concentrate on this area. And now we're asking our managed care organizations across the state to make a difference across the state. So making progress so far, having identified the issues, and now there's more work to be done, but we know some of the things that can work.
Thank you. Let me bring Dr. Nathan Chomilo in. He's in the department with you there, Department of Human Services, and his background I'll share with you briefly and have him join the conversation. His work has, second here. Has centered on the impact of early childhood intervention and healthcare access, the impact that they have on the long-term prospects for children, and on how physicians and health systems can address racial and health equity. So Dr. Chomilo is the medical director for Minnesota's Medicaid and Minnesota Care programs, and he practices also as a general pediatrician with Park Nicollet Health Services Health Partners. He's also served as the state of Minnesota's COVID-19 vaccine equity director and as senior advisor on equity to the Minnesota Commissioner of Health. He's got a degree in zoology from Miami University and graduated from University of Minnesota Medical School. He's completed a combined residency at the University of Minnesota, and he was a pediatric chief resident at the University of Minnesota Children's Hospital. He's a member of the American Academy of Pediatrics, AAP, section on minority health, equity, and inclusion, and he serves on that group's executive committee. He's a member of the board of directors of the Minnesota chapter of the American Academy of Pediatrics and a fellow at the American College of Physicians, an adjunct assistant professor of pediatrics at the University of Minnesota Medical School. And he serves on the board of directors of both Reach Out and Read Minnesota, Reach Out and Read National, as well as the steering committee of the Minnesota Perinatal Quality Collaborative. He's a member of the National Committee for Quality Assurance, Equity, and its expert work group. I'm not sure I'm saying that the right way, but he was selected for the National Academic Academies of Sciences, Engineering, Medicine Committee on Improving Health and Well-Being of Children and Youth through Health Care Systems Transformation. Well, all of that, Dr. Chomilo, so impressive, and we are so thankful for what you do, for who you are, and the work and the voice you bring to the work. So let's go through the same question. What about maternal health? What does your organization and your work do to support, encourage, elevate the health of women and maternal health care?
Yeah. Thank you, Al. Thanks for having me back on. Great to be back here. Thanks to Commissioner Harpstead for shout out to the work that I've been doing at the agency for the last 3 years. I think I came to Medicaid because there was a lot of opportunity to really center our community in the conversation around how do we address health and health disparities that we've seen. And we've been measuring them in Minnesota for well over a decade. And so how do we kind of move from that measurement to action? And so I was very upfront is that, I want to talk about the impact of structural racism in our programs. I want to talk about how we could be more community-led and how can we focus on where many of these disparities start, which is, from birth and seeing it with our mothers, our birthing persons, supports our mothers and fathers do or don't have, and then how that impacts our children. And so I was really excited to learn one of the first programs I really dove into was the Integrated Care for High-Risk Pregnancies program, we affectionately call iChirp, that was started before I joined. By my predecessor, Dr. Jeff Schiff and Fritz Anzak at DHS, along with community members, and really focused on our African-American community and our American Indian communities, where they got together and they came up with a model of collaborative care that looked at what are the many needs that families have when it comes to entering the birthing experience, what's the supports that we can bring to bear once we identify those needs, and then how can this be kind of an ongoing process where we set something up, put it in place, but don't just think that it's going to be perfect the first time out the gate, right? Like we're going to keep having to come to the table and talking about how we can continue to improve it, continue to really, again, find ways to share power in this way, find ways where the state can help provide resources, but doesn't have to have the final say over every little piece of that, and how the community is doing so many different things already that just need the state to maybe sometimes get out of the way and let them do what has been working, and provide the support and resources for it to expand, and so that all mothers, birthing persons, fathers have access to that. And so the work with iChirp, particularly in our community, it is now called Healthy Black Pregnancies, has continued to grow and expand. We were able to get additional funding in 2021 for that, as well as thinking about across the board, how do we make sure that folks continue to get access to healthcare? One of the things when we look at our maternal mortality statistics, right, a lot of the mothers who lose their lives, the birthing persons who lose their lives, it's in that first 3 to 6 months after they give birth. And historically, our policies have said that you qualify, and it's a lot easier to qualify for Medicaid while you're pregnant, and then you had 6 weeks, 2 months or so to stay on before folks would get kicked off of their coverage. And so one of the other things that came out of a lot of work from the community, including, I'd say, Representative Bruce Richardson and her work to declare racism as a public health crisis in the Minnesota House, that led to the selective committee that her and Chair Rena Moran co-chaired, select Committee on Racial Justice that put forth a recommendation of expanding Medicaid coverage to 12 months after a woman or a birthing person gives birth. And so that also passed in 2021 and is now in effect. And so I think those are some of the real key pieces that we're proud of that we've worked on, but we know that there's a long way to go, and getting folks access to care is really important and crucial. But then what I've heard so much in conversation is that care continues to be biased, and that care continues to treat folks differently, so that maybe they don't want to even show up, or when they do show up, they are falling through the cracks, they are experiencing complications that they shouldn't be, because we have work to do on how do we kind of incentivize better care, not just access to care.
Part of it, I think, is the public intimidation. I think we've crafted an expectation or an appreciation of the profession that deserves the profession, because it puts providers in a seat of pontification and puts the needy, the patients, the customers, in a position of having to genuflect at the altar of perceived and real knowledge. And therefore, there's a power dynamic that makes people not want to look for help or not know how to look for help. So my question is, how do we change that? What do we do to educate consumers in general, Black people in particular, to have a sense of agency, a sense of appropriate equity entitlement, and to dispel any internal dialogue or tapes or misunderstandings that keep us from being active participants in our own healing in a way that we should be. What do you think, Dr. Chomilo?
Yeah.
Is it a fair question, first of all?
It is a fair question. It's exactly where a lot of our efforts and focus needs to be. But I'll also be the first to say that I don't have all the answers. And that's why I'm so grateful for the collaboration with the ICHR program, with community who have been in conversation for years and years and decades about, what is needed and how do we best reach birthing mothers, birthing persons, fathers, community members about what does the experience, what should it ideally look like, and how does it meet their needs? And so I think that the piece of it, that's part of what Healthy Black Pregnancies does, is not only thinking about the care model itself, but the education and engagement of our community around what their options are and what their rights are. I think a part of it is how can we get more of our workforce to look like our community? And so right now, roughly like 1% to 2% of physicians or advanced practice nurse practitioners identify as Black in Minnesota. Well, we make up around 7-8% of the population. And so we have work to do on the workforce for physicians. I also think thinking about other types of care, so doulas, midwives, other forms of care and supports that we don't maybe think right away of being really helpful or critical to our healthcare system. So how do we elevate those, make sure that we see a way to sustain those careers and develop that workforce as well. And then I think even thinking about our levers of accountability. So the commissioner talked about how we're looking at things like the prenatal and postnatal care visits as a quality metric and trying to decrease disparities in that. But I'm also really interested in evolving beyond what we currently measure and define as quality, because so much of what I've heard is that it's not these kind of whether or not you showed up to the appointment, whether or not you had a certain test done or not. It's how you were treated, how you experienced your care. And so those kind of patient experience indicators, there are folks that are working on collecting that data and then doing it in a way that we can start to hold providers and health plans accountable for the experiences our community members have, and building that into our systems, I think, is where we need to go to really, again, kind of capture and kind of confront what you were really talking is. It's out there because it's happened. We all, I think, have family members who have showed up and gotten care that they don't deserve, like largely because of our race and our skin of our color and the racism in the healthcare system. And so, we need to find ways to address that in like starting with the education of providers, but then how do we also hold systems accountable using the levers we have through payment and quality measurement and things like that.
Well, the question the commissioner passed over to you to respond to is, what do you do with the tools you have to withhold money or to reward contracts for people that score in the right level in your equity index. How is that working? Do you have evidence now that you've been successful in creating improvements or movement in the direction that you envision?
Yeah, so I think we're still early in that. In
Mhm.
fact, some of this work started when the pandemic hit, and some of the ways that we usually measure quality we weren't able to do because people just weren't able to get to their provider. Providers' offices were closed. People were told to stay at home, and so we used that time to start looking at the kind of logistical pieces of like how do we actually look and measure a decrease in disparity and outcomes along the lines of race. And so we did some of that groundwork in 2020. And so 2023 is one of the first years that we're really kind of going forward with these new metrics to see, can it help move the needle? And that's something that, in addition to measuring these things, we also are asking our managed care partners to really themselves demonstrate that they're engaging with communities that face disparities and health disparities and show that to us. And then that is information that we post and have public for folks to look at. It's very technical in the way it's structured now. So I'm also very interested in how do we make it more digestible information that we can share, and coming back into spaces like this and sharing that when it's ready is certainly some of the work that I'm looking forward to doing.
Let me ask you, I've asked you this before, but always great to hear your story. How have you come to the profession, and how have you come to the work that you're in now? Where are you in your own career? I'll start by saying, who were you when you were 5 years old? And what was your dream of what you'd be as you grew?
Yeah. So when I was 5, I was living in Joliet, Illinois. And I think I'm trying to think back. I think like a fighter pilot was one of my top career aspirations at the time. I thought that would be really fun. But I also had a doctor's bag. My mom's a nurse. My dad's a pharmacist. My dad came to the country from Cameroon in West Africa with the thought of going to medical school and landed in pharmacy school. So I've always kind of had those messages of being interested in healthcare, and so went into medicine thinking not only to kind of be someone who can help someone at the bedside or in the hospital, but someone who could be help my community and help really address the health needs of the community. And so I think that's what ended up leading me to Medicaid, is that I've done a lot of work in early literacy and with Reach Out and Read Minnesota, done a lot of work and some of the addressing the healthcare system writ large through Minnesota Doctors for Health Equity, but a real chance to kind of, we live to better or worse, we live in a capitalistic society where money moves
Mhm.
things. And so how can I learn more about those levers in our healthcare system, help educate myself about that, but then help educate folks I work with about what role structural racism is playing in that, and then kind of figure out how we can get out of this cycle of disparity and racist outcomes that we've seen for generations. And so that's what the work that I'm still doing here, and within that is really how do we center community better? And again, so many of the solutions are there in community. We just haven't listened. We haven't elevated, given them the supports they needed. We haven't, when we talk about quality or what we value, it hasn't been in the terms of what the community values, or the community terms as quality. And so how can we shift that and have these systems, work more for us instead of kind of against us?
Are you surprised at the number of people who don't know what Medicaid is and what the differences are between Medicaid and Medicare? What's your experience? And maybe in answering that, let's take a minute and let's do Medicaid 101. Give the definition so that somebody listening right now might have a new understanding coming from the expert.
I'm not surprised, because there's folks who make it through medical school and have a hard time telling you the difference between Medicaid, Minnesota Care, and Medicare. And so, Medicare is our federal program. So, controlled by folks in DC and Congress, that helps give health insurance to our elders, so those 65 and up, and then certain folks who qualify for it through disability or other healthcare needs. And so that's just an age requirement, essentially. Medicaid is a federal and state partnership where the rules vary by state as a result. But basically, the federal government pays part of it. In Minnesota, it's around half. The state government has to come up with the funds to pay the other part. And then you get to define what is covered in that. So who is covered based off of income, usually. Again, there's different variations for disability and other conditions, but basically income is the biggest one. And then age as well. So children eligibility is a little bit different than adults and whatnot. And then in Minnesota, you're eligible for Medicaid if you're on that lower income spectrum. And so generally it's for low income folks, who are working, but their insurance doesn't provide, or their employer doesn't provide insurance, and they're not making enough money to afford it on the individual market, that type of thing. And so that's the difference. Is, Medicaid is more for our low income folks versus Medicare, which is for our elders primarily.
Thank you. Let's shift and bring in Dr. Diane Banigo. Dr. B, she allows us to use. Doctor, good to see you. Thank you for being here. Let me tell our listeners and viewers that Dr. Diane Banigo is a doctorate-prepared nurse midwife, a perinatal consultant, an adjunct faculty, and a small business owner with over 21 years of women's health experience. She's been a leader in Minnesota's Healthy Black Pregnancies movement, and she previously called, which was previously called Integrated Care for High-Risk Pregnancies, a pilot focusing on improving maternal and child health outcomes for African American community. She's passionate about supporting people from all walks of life. She's worked as a midwife in partnership with doulas, complementary therapists, and esteemed providers for over 20 years, bringing people comprehensive care. And when she's not at a patient's bedside, she's somewhere in the community helping other people or other organizations cultivate change through the project called Ignited Faces of Beauty, or Igniting Power of Women. And both groups foster collaborative work with organizations and individuals who are ready to design and implement culturally responsive and inclusive solutions to the disparities, to also model equity, and to fire up, to ignite leading innovative change. Dr. B, so good to see you. Welcome to the conversation. And I'm sure you got a lot to say based on the first two conversations. And what we'll do is jump in with you for a minute and then bring our two guests back in for a round table. But thank you for being here. And so what's the main statement about your work in your organization right now about serving the maternity needs of our community?
Thank you for having me, Mr. Al. And I would just say one of the things about being a midwife, which is with women, just my profession has led me into a lot of different roles in maternal health. Like sometimes I'm the baby catcher. The next time I'm a shoulder to cry on. Sometimes I'm a circle facilitator. Sometimes I'm a fierce advocate. And since the inception of Healthy Black Pregnancies, or ICHIRP, I have kind of morphed into this role of being a community partner, community consultant, and cultural broker. And I think my position has afforded me the opportunity to just stay close to the community and keep my ears open. I think a lot of times when we try to figure out what is the secret sauce, we miss the key ingredient, because the people that are trying to create the change are so far removed from the issues in the community at hand. And by being in this role, I get to stay close to the communities and just hear, so that I can actually translate what they're experiencing to what needs to happen in the system. And so I would say my biggest role is just being a cultural broker and being able to be in different settings and having the ability to translate what's going on to what needs to happen.
So how do you translate the egregious reality of the disparities? What can you say about that to our people? On the one hand, we know it because we experience it. On the other hand, the expansiveness and the structural nature of this machinery that disadvantages us while it's supposed to be serving us is overwhelming. What do you say? How do you translate that to people being knowledgeable and into action against that which oppresses us?
I mean, I think it's twofold. I think you have to work at it from both the inside and outside, and that's one of the reasons I went back to school to get a doctorate, is so that I can receive the invitation to the table where these discussions were happening, because I saw a lot of profiling and isms, as I like to call them, show up in the birthing space. But in the community, when we're with the families and birthing people, we talk to them and give them words and the verbiage of what's going on and try to explain it. Because I often say in this work, some of the harder people to convince that the system has structural racism embedded inside are the people that are actually experiencing the trauma. And so we just talk real about what's going on and how is that making them feel. And then we kind of connect the dots for some of the historical trauma that our communities have experienced. And then on the other side of it, we're actually having conversations with the leaderships in some of the health systems in the Twin Cities about how exactly what was said and what was done, how that is eliciting certain feelings, how that is connected to perinatal mental health, how there is a hole in the system. And this is what the community said needs to happen for them to fill it. And so we create soundboards for the community with the system so that we can bounce ideas off of it, so we can get it as close to right as we possibly can. And this is not a one and done. And so our job in the community as a broker is to make sure that we continuously have these conversations, because situations change and women experience things differently. And we also make sure we create space to listen to the males and partners. And so Black men aren't so feared, and they're actually considered as assets to trying to get to the care goals that we want to get to. And so we create space, a safe space for women to show up authentically and be honest, and don't have to code switch. Another segment for another day, but they don't have to code switch. And then I can use my medical background to go over into the leadership system and tell them what that really means. And also use my own lived experience as being a Black woman, descendant of slave, in this system, and how I'm treated even as a provider with all my supposedly accolades, and still know how it feels to show up in that space. And I try to use that lens of transparency to help them have an aha moment.
Let's go there. You talked about code switching. Sit in that for a minute. What do you mean, Dr. B?
Let me see. So, just the overall code switching is the things that you can say in a space when you're amongst your peers, amongst people that have similar lived experience. It can just be as raw, right? We don't have to be politically correct. We can just say what we feel. We can cry. But when we're in mainstream and in the presence of others, we have to put on this mask, and we have to position ourselves so we think we're going to be able to afford us a little bit more respect. And that's not always the case, especially for Black and brown bodies. And so we allow the rawness, the unfiltered, some of the profanity or whatever that they felt, and we let it, we just let it sit and simmer, and then we package it and extrapolate to make sure, okay, this is what we heard, this is what you were saying, so that we can make sure that the message we're getting back to the leadership is actually what they experience, and take some of the emotion out of it. But then also we do, when we have our interviews, we let them hear some of the rawness, because then they understand how real some of these experiences of structural racism are for the people that are experiencing it.
It's like, since they don't think we're human, that's premise one. They question our humanity, and we become academic rather than empathetic companions in the process, the experience of life itself. And they act as though we don't have an opportunity or a need or capacity or an interest in stewardship of existence itself, that is their idea and not ours. And they get offended when we raise our voices and show up as our authentic selves. Am I on the right track?
Yes. And I would also add that, this is an exception and not the norm. People seem to get impact and intent confused. And so we want to make sure that we keep them honest. And I feel like now that we have, racism and implicit bias and all the maternal health numbers, the crisis just getting a spotlight, a lot of times I think the system and I would say mainstream need to be aware is that just because you had a DEI training, it does not replace the lived experience of Black and brown people. So there's this false pseudo expertise that you think that your training can actually afford you a certain level of privilege, and it just does not. And so we need to make sure that as we're continuing to do this work, and we're not calling anyone the bad people, and we like to keep it a system, but if there is a particular person that needs to be redirected, that they're allowed to be redirected, and the systems are in place to allow for that correction to happen, so that we don't keep perpetuating harm, which is what we hear when we facilitate a lot of circle spaces. One provider may get it right, but then it has become a culture of I know more than you, and we don't share power and privilege. We don't level the playing field so that they can also be stewards and have self-agency, especially when what you're recommending goes against what they want or what they believe. And so we have to continue to massage that conversation out in real tangible ways so that people can get it. And so that's why it's so important to have people like me in spaces to kind of broker that conversation and buffer sometimes some of the animosity that is not to you personally, but to the system or to the experience, so that we can actually get where we're trying to go and all get there together.
What's your background? Where did you start, and how did you come to the work?
I would say
Who was the 5-year-old Diane Banigo?
The little kid that was kicked out of the library. And so when my mom moved us to Minnesota from Chicago, and to Frogtown, I'm a Frogtown Rondo girl. I actually found a book on how to birth babies, and my grandma read it to me, and I got kicked out the library at Groveland because I was telling everybody where babies were born. And so I've always knew that I wanted to deliver babies. I thought I was going to be an OBGYN, got into the pre-med program, dropped out because one of my professors, Ray DeFries, if you're out there, find me, at St. Olaf, was like, you seem more like a midwife. And I didn't know what that meant. And so I just decided to go down that path. And so, go for nursing, med surg, oncology, go back for midwifery, go back for my doctorates in leadership. And what I've learned is that the term midwife, meaning with woman, has evolved. I used to think to be a midwife, I had to be at the bedside, but I know now that it has evolved and it means to be with women. And I have been at the state capitol advocating for some of these bills we need. I've been with women as they lose their babies and their babies take their last breath. I've been with dads that I have to explain what's really going on. So midwife means with woman, and I am just so grateful that I've had an opportunity to be with women and their families in so many capacities to try to help make sense of this chaotic and just crazy world, and to be able to cry with them and let them know I don't know it all, but I am human. I see you, and people just want to be seen.
Let me ask you and Dr. Chomilo. Doctor, you said you have your dad's Cameroonian. And I want to raise with both of you the question of your lineage, of your history. And I'm into what is being described as an Africana way of knowing. How do we look at and through our own cultural lens? And that's the lens of African people. And maybe it's even to the degree that we can study it or divine it or feel it, a feeling of that places us at the center of humanity and gives us a certain agency and a certain authority. So where does lineage come in for you, Dr. Chomilo? I'm particularly asking about your Cameroonian heritage. And then Dr. Diane, same question for you.
Yeah, I mean, I always been fortunate to know a lot about my family and my roots. And so, my father, we can trace our roots in Cameroon all the way back to like the 1300s, and have some connections to, some of the kingdoms in the area of Cameroon that my family is from. And so,
have you been there?
I haven't. They're actually currently going through a bit of a civil war. Doesn't make the news because it's Africa, right? But
is the family from Bamenga or Bafut? What part of Cameroon?
So my family is mostly from Bamenda, in West Africa. The kingdom I'm referring is Fumban, and so in fact we gave my son his name is the first Fumban king in Chare, and so yeah, and I was back there in about 15 years ago now, in my early 20s, which is really transformative to kind of help me further connect and understand. the duality, right, of seeing how I exist here in the U.S. and treated here, how I exist in Cameroon, the impacts of white supremacy and our brothers and sisters in Africa, and how that plays out here, and then how they kind of try to sometimes pit us against each other, right, here as well, and how that plays out. And so, talking about code switching, that's like right up my alley as a kind of a biracial Black man, raised in the U.S., have African connections, and so I've really found myself, taking, it's not easy getting to this space, but I think it's been a gift that now I reflect on, that helps me be that broker navigator that Dr. B is talking about in different spaces, both at the kind of professional state level, but also in community, and how we can kind of, understand how we're all impacted by structural racism, white supremacy.
And so, Dr. B, what's your relationship with your ancestors, with the ancestors?
I mean, just want to touch on some things that Dr. Chomilo said. It's just really important. I always say that I'm a descendant of slave, and thanks, to the new DNA test, and was able to kind of trace back, my roots, if you will, and to actually honor that I'm Nigerian. And I always give my my kids a hard time because my husband is actually Nigerian. And so I tell my kids that they are truly African American. And so in the almost 20 years that we've been together, we go back. I actually have a house in Nigeria. And so I go and I'm actually amongst my people. And it is a completely different feeling than even being here amongst my people. And so because I have been able to be there, have a house there, live there, meet with the women, learn about the, some of the birthing practices, I can even broker some of that conversation and that conflict that Dr. Chomilo talk about between the Africans, native born and US born. And I think we really need to challenge our education system, because the way that they talk about Africa, the motherland, and the people that are from it is so demeaning that I'm not surprised that people want to disassociate from their roots. And so we need to continue to check that education system, but we also need to know that there's strength in our legacy. Some of the things, when I just think about, mental health and just some of the healing practices, there's so many things that we just don't acknowledge that are organic and herbal. And so we don't make the most of some of our traditional healing practices, like some of the different, herbs that they put in the pepper soup, and like to heal your body and to cleanse you of some infections. So I think that if we were to build a bridge and actually focus on the strength and the assets that African people have brought to this country, then more Black Americans that are born here will stop trying to disassociate and actually be intrigued to learn more about their roots, so that we can infuse it into the future, because there's something to be said about the strength and resiliency that our people had and why they survived so long. And so we definitely have to go back. Everyone that has an opportunity should go to the motherland, and I'm biased, that's my bias, and just see it's so different. It is reviving to actually know that you come from such source of strength. And so I would encourage everyone, tickets aren't cheap, but we still need to still need to go. That should be.
Are you Yoruba or Igbo?
My husband's Ijo, and so I say we do have a house there, and so if you need to come, we have a room.
Amazing. So Jodi Harpstead, come on back in. And I'm glad we're having this conversation. This is a family conversation, but you're part of our family as well, because I think that what we do and what we mean, what we intend, is to say that our sense of being at the center, of placing ourselves at the center of existence, necessarily means that everything else in existence is related to us. You belong to us and we belong to you. We belong to each other, and that all of us are strengthened by each other. The failing that we have been for each other is a point of view that allows a few to manipulate and control the many to the disadvantage of the many, and for the personal gain, or maybe it's the fear-based, whatever it is that drives the few to hoard money, wealth, health, power. But at the end of the day, we all have to figure out a way to reorganize our relationships so that all of us can be our very, very best human beings. What do you think? How does this story sound to you just listening, Jodi Harpstead?
Yeah. Well, first, I just want to say what those two said. Those two said. I'm just sitting here continually listening and learning, and I'm so grateful for the opportunities I have in this position to do that. I also want to thank these two so much for all they've brought to our work. Dr. Banigo sharing her stories from her work with Dr. Chomilo, who's now in a position to say, we need to do something about this through Medicaid, and able to bring me a proposal that I can help get through the legislature at the end of session on behalf of the governor, or sign multi-billion-dollar contracts with our managed care organizations that put healthy Black and Indigenous pregnancies as a metric in those contracts. And so I'm pleased that the three of us are simply 3 points away from each other and not 50 points away from each other. And so Dr. Banigo's experience can turn into Dr. Chomilo's proposals, can turn into me using the position I have to see what we can get across the bridge and make a difference. And so I'm pleased with some of the progress that we've made. There's a lot more to do, but it's been just lovely to partner with community and just listen and not come in ready to go fix everything, thinking I know what to do.
So part of the challenge, Commissioner, is just that sentiment when people come and say, I have the answer, and they are oblivious to and unwilling to accept our lived experience as being of value. It really disserves both the official, the person who has the assignment on behalf of the people, the state, right? And therefore disserves the person who's seeking to be both healed and supported and helped and enabled to be an effective citizen. And where and how do you see the resistance in the establishment? And I'm asking you as a white person who's been in leadership for a number of years in a variety of professions, how would you describe things that you might hear Al McFarlane describe as a barrier, as a legacy of exclusion? How did that happen, and what does it take to change it?
Well, it's a pretty known fact, I think, in sociology that folks that have the most can allow themselves to be deaf and blind to what's happening with other folks in the community, and don't need for their own survival to go find out what's going on with other folks in the community. And so that's easy to fall into. One of the things I have learned from these two over the last couple of years is the data that we have on these disparities in Black and Indigenous birth experiences have so long been written off as something that the mother has done wrong, or has neglected, or was too poor to do well. And we're learning that it's the system they walk into who doesn't treat them right and doesn't listen to them and doesn't help them with what they need. And so we have been trying at the department feebly for the last couple of years to really start co-creating our work with community. It takes some fumbles and stumbles and attempts that don't work and things that do for us to learn how to listen and share power and really truly give the community what they need to thrive, because they know what they need to thrive. And if we can focus our energies, instead of coming in and saying, here's what I want to do to change Minnesota, to just stop and listen to what community across the state says they need. And then our job is to turn that into policy and funding and regulation and get it out there. That's when we really start to respect each other's cultures, each other's backgrounds, and make Minnesota work for everyone.
Where do interests collide? Here's an Al McFarlane-ism. I'm often saying in my critique that they get the money, we get the misery. Our misery becomes their business. Their incentive is simply to manage the business, because it's an opportunity that doesn't go away. If you manage it, it'll be here for generations and generations, providing mortgage payments, car payments, college education. But the principle is, how do you farm the misery of the poor, and particularly the Black poor, people of color? So that's my critique. It may be unfair, but I say it all the time, and I hope that someone can say, Al, you're wrong. but I hope to fix the problem. That's one. The other part of that is that I tell people that my grandma used to tell me, when I was 5 years old, boy, mind your business, right? Meaning kids stay out of grown folks' business, but there's a double entendre there as well. Not so much don't be nosy, but the mind your business part is take care of your business. Pay attention to your business, right? And so then how do we take that command, that instruction from the elder, the grandmother, and announce to ourselves that our health is our business? That's my business. My health is my business. And I have an obligation, a duty, and a right to mind that business. And to me, minding the business means being conscious of and in control of the revenue streams associated with that business, the jobs that get created, right? The contracts, as you've said, Jodi, if you're in a position where you can direct and expand flows that create knowledge, power, opportunity, wealth, and a reimagination of the disparity, not as a disparity, but as a different opportunity for those who are afflicted by the disparity. It should be perceived as an opportunity and a place for growth. We should be able to cast ourselves in the image of solution makers. We're the solution. And we've been described as the problem, and the disparities narrative, is about a problem. So let's change that around and say, you know what? We are here to solve the problem, and we have to demand and expect the resources to solve the problem. Dr. Nathan, what do you think about that?
Yeah, I do think that, I was thinking about your question to the commissioner. I think there is a thread there in that, in my experience, when I talk to folks about structural racism being the cause, that it's racism, not race, that drives our disparities, right? What that does is actually it challenges folks' narrative of themselves. And it challenges folks' narrative, particularly, so again, I'm biracial. My other half is Norwegian. There's a lot of great service organizations founded in the Norwegian community here in Minnesota. And to your point of, them helping maintain misery on some level, but they don't see it that way. They see it as they've been helping the afflicted, right? But they haven't challenged themselves. And what I try to do is they haven't challenged themselves to see how are they benefiting, from the system, and what discomfort are they pushing to the side to not deal with so that they can continue to be comfortable, while thinking that they can, just pat themselves on the back for the work that they're doing. And so I think those narratives really get challenged. And then when you talk about as Black folk and as folks in our community taking charge of our health, we have to think about the narratives we've been told and we've been growing up. I often cite Dr. Beverly Tatum, who wrote a book, Why Are All the Black Kids Sitting Together in the Cafeteria, who talks about how we all breathed in the smog of racism, right? We've all internalized these anti-Black messages. And so, maybe we hear someone say that, we are more sick because we make bad decisions, and we think that that is the only reason. And so we internalize that instead of thinking about, I got to take care of myself, but then how can I use the spaces I'm going to help lift us all up together?
We're out of time. Listen, Dr. Nathan Chomilo, thank you so much. Dr. Diane Banigo, thank you so much. Commissioner Jodi Harpstead, thank you so much. Continued success. All of you are welcome to be here to bring the story as often as you wish. I thank you so much. I'm Al McFarlane. This is The Conversation with Al McFarlane. We'll see you next time.